Welcome, everyone, Kentuckians and a few people from other places in the country. This is the regular first Thursday meeting of Kentuckians for single-payer healthcare, but we decided that we would dedicate this meeting to an educational program so that we can all learn about value-based healthcare and what it means for our movement and our efforts to win a national single-payer healthcare system. So we are after Anna will present for a period of time, and then we will have questions and her response. And you can put questions in the chat if you like, and I will try to get them out. Or if that doesn't work, we can take hands and call on you. We will go until there are no more questions, or until 6:30 Eastern time, which is enough for us to spend on the topic. Let me introduce Anna. I think everybody seems to know her already. She is very recently retired pediatrician, and she has worked in Texas and in Pittsburgh, and she's currently in San Francisco. And everywhere that she went, she not only cared for sick children, she has also built the national single-payer healthcare movement and the Physicians for a National Health Program. She's a past president of that national organization, and she was kind enough to agree to do this program for us on value-based care. So I give you Anna Malinow.
Let me share the screen here. So thank you, Kay. Thank you everybody else for attending, and thank you to the Kentuckians for Single-Payer Healthcare for inviting me to speak about value-based or value-less, from the boardroom to the exam room, Medicare, privatization, and the menace of value-based care. What we're about to discuss in the next 35 minutes or so is complicated, so let's go ahead and get started, and I'll be very happy to answer questions at the end. Okay, let's see. There we go. So this photo from the New York Times from July 1965 shows President Johnson signing Medicare into law, and seated next to him is President Truman, who was the first U.S. president to call for Medicare for all, not just those over 65. And on the right, you can see the very first Medicare card issued to President Truman, who was the first American to get Medicare. And in this photo, you will notice that the only two people who are not smiling are Presidents Johnson and Truman. And I think the reason they're not smiling is because they understood how much sausage making it took to get Medicare passed into law. In his book, The Social Transformation of American Medicine, Paul Starr writes about the politics of accommodation required to pass Medicare into law. Believe it or not, Medicare did not just suddenly get written and passed in the year 1965. The passage of Medicare started at the turn of the century, the 20th century, making Medicare a hard-fought 50-year fight. And to win, President Johnson had to accommodate powerful factions, hospitals who did not want to lose their profits, the not-for-profit health insurance companies that were then called the Blues, who were very happy to get the sick and the elderly off their hands, the American Medical Association, the Association of Physicians, which was virulently opposed to Medicare, Republicans who did not want to give the poor any unearned handouts, and the Southern Democrats who did not want to give Blacks any unearned benefits. And the final arrangement of Medicare with the different parts surrendered the terms and the costs of the program to these players. And as we will see throughout this presentation, so it's the thread that goes from slide to slide to slide, the interests of these powerful players, you know, the hospitals, the insurance companies, and then the doctors, shaped Medicare to maximize their profits at the expense of taxpayers from the beginning of Medicare in 1965 to today's value-based care. Now, let's take a look at total Medicare spending from about 1970 to today in billions of dollars. And the Medicare budget, which started in 1965 at $10 billion, actually went down a bit in 1970, but as you can see, it's been going up every year since then. So the budget that started in 1965 at $10 billion is today almost $1,000 billion. And remember, the certain interests shaped Medicare to maximize their profits, and maximize them they did. But you can say the number of Medicare beneficiaries since the beginning has also gone up, and you would be right. And so if you look at Medicare enrollment in millions from its beginning until today, you can see that it started almost at 20 million individuals, and it has been going up every year. So the enrollment that started in 1965 as 20 million beneficiaries today is about 65 million beneficiaries. Now, that means that since 1965, the total number of Medicare beneficiaries increased threefold, but costs increased 100-fold. Now, why is spending going up? Well, according to American health policy experts, there are two reasons why costs keep going up. One, greedy American doctors ordering too many tests and performing too many procedures. And greedy American patients who see too many doctors, ask for too many tests, and get too many procedures. And here you can see the typical greedy American patient in this cartoon hooked up to his condensed chef salad through his IV. This is known as fee-for-service, and according to American health policy experts, is the reason healthcare costs keep going up. But what is fee-for-service? Well, fee-for-service is actually not that complicated. It's the way doctors get reimbursed under traditional or original Medicare. Now, if you have traditional Medicare, you go to your doctor who performs a service, who bills Medicare for that service, and then Medicare pays the doctor directly. You see, there is a straight line from Medicare to the provider. Nobody managing your care, nobody between you and the doctor, or between the doctor and Medicare. Nevertheless, fee-for-service has been blamed for America's high costs compared to peer nations for the past 50 years. But let's take a look at a couple of these myths closely. Some say our costs are high because we use fee-for-service. But if you look at other countries who also use fee-for-service and compare their healthcare costs as a percent of gross domestic national product, you can see that over time, I think it's from 1983 to 2017, the black line above, which represents US healthcare costs, are much higher than the colorful lines, which are the healthcare costs of peer nations such as France and Germany, Sweden, Canada, Japan, and so forth. All countries which also reimburse their doctors using fee-for-service, and they spend much less than we do here in the US. So it can't be that our costs are high because we use fee-for-service. Now, another myth is that our costs are high because we just get too much care. You know, those greedy American patients, those greedy American doctors. But if you ask Americans, what percent of Americans skip care due to a cost in the past 12 months, you see that 33% of Americans skip care compared to much lower percentages in other countries, in Switzerland, France, and so forth, and just 7% in the UK. And this is data from 2016, but in October, the Commonwealth Fund published another poll that showed that in 2022, 38%, so almost 40% of Americans skip care due to cost. The bottom line is that all these myths about fee-for-service and greedy patients causing our high costs are busted. Now, just a word about sources, and you will see that just about all my slides do have sources that you can go back to and confirm the documentation. I know that sometimes it sounds as though I'm making this stuff up, but really it's based on evidence. So what really drives up healthcare costs in the US? Prices. For example, you will pay much more to get your appendix removed in the US compared to Canada. 30% of our healthcare dollars go to administration. Our healthcare system is extremely fragmented, which leads to duplication and higher costs, and consolidation, where small hospitals are gobbled up by larger hospitals, which are gobbled up by even larger hospitals, all leading to consolidation, which results in higher costs. So what is really driving up healthcare costs is not fee-for-service, but our prices, our administrative costs, our fragmentation, and our consolidation. Since the 1970s, though, American health policy experts believe that the way to control high healthcare costs caused by fee-for-service is for Medicare to pay a middleman an upfront capitated payment per member who will share the risk of caring for the patients and decide who gets what, when, where, and then pays the doctor, the hospital, the providers, and gets to keep a certain percentage of the leftovers. So Medicare is giving this public money, a pot of money, to a private middleman. Now, over the years, this private middleman have been called health maintenance organizations, or HMOs, Medicare Advantage, Accountable Care Organizations, or ACOs, and as we will see, ACO REACH and the Medicare Shared Savings Program. Now, this dogged refusal to look at the true drivers of health costs, remember all those powerful factions trying to get as much money as they can, and a persistent obsession to blame fee-for-service will result not only in the wrong diagnosis, but also in the wrong prescription, as we will see. Now, another way of talking about transferring public Medicare money to private middlemen, such as Medicare Advantage plans, is privatization, which is defined as the transfer of public funds to private hands. And we can see just how much Medicare has been privatized from before 2003, when most beneficiaries on Medicare, those in blue, chose to remain on traditional Medicare, that was then called A and B, or still is, and only a very small slice in green chose a private health insurance option to manage their care, which was then known as Part C. But if we fast forward to 2023, you can see that 50% of beneficiaries now choose Medicare Advantage, a private, usually for-profit insurance plan to manage their care. After 2003, Part C became known as Medicare Advantage. And the other 50% remain in traditional Part A and B, also D, and a supplemental plan. And these are the individuals who want to be able to choose any doctor, any hospital without having to ask for prior authorization. So 50% of Medicare is already privatized. That's the green, the money part. Now it's the blue part that is at risk of being privatized as well. And this is where we're going to focus our attention for the rest of the talk, right there in the blue slice of the pie, known as traditional Medicare. Now, to control costs caused by fee-for-service in Medicare Advantage, commercial plans are paid through capitation, or upfront payments for each beneficiary. Now, needless to say, commercial plans love this upfront payment because that gives them plenty of opportunity to keep the leftovers. And in traditional Medicare, in the blue part of the pie, something called value-based payment and accountable care organizations were established under the Affordable Care Act, and we're putting emphasis on value and accountable and care. Medicare would now pay for value instead of volume. Now, let's have a little timeout. What is value? Well, value is good. No one is going to argue that. But if we are going to base our payment on value, then we're going to have to measure value to pay for it, right? But how do you measure value? We are much more likely to choose something that is easily measured, such as blood pressure, than happiness or social support, which are just as important to your health. So already our value measurement will be biased and not necessarily a reflection of true value. Now, then the question is, okay, we will just measure what is measurable, but there are over 10,000 what they call CPT codes. These are the codes that all providers use for medical services for reimbursement. We can't possibly measure everything. So we will choose a sample of measurable services among those 10,000 services. And what happens to those services not measured? Experience shows us that doctors stop paying attention to those unmeasured services and pay lots more attention to the services being measured. They teach to the test. And in a system that rewards physicians for value, what happens when a patient sees multiple doctors? Can it be that the system will reward one doctor for the value created by another doctor? If value can't be defined or measured, should it really be the metric to reimburse and reward medical care? Well, apparently so. Now, the next big question is, what is an accountable care organization exactly? Well, the formal definition comes from the Affordable Care Act that established ACOs. Accountable care organizations are a group of providers of services and suppliers who work together to manage and coordinate care for Medicare fee-for-service beneficiaries and who are eligible to receive payments for shared savings as long as they meet certain performance standards. So let's translate this into English. ACOs manage care for beneficiaries on traditional Medicare and get to share the savings that they generate. More precisely, ACOs are middlemen who agree to assume financial risk to manage the care of beneficiaries on traditional Medicare and share the savings that they generate with Medicare. To be accountable means to share the financial risk of providing medical care, not unlike Medicare Advantage. Now, another term that gets bandied about quite a bit is population-based payments, which is nothing more than capitation. So now that we have these definitions out of the way, let's answer the questions. What is value-based payment? Is it different from value-based care? And why should we care? Well, spoiler alert, value-based payment is the new managed care for traditional Medicare codified by the Affordable Care Act in 2010 to move doctors away from fee-for-service to value-based care, accountable care organizations. It has little to do with care, nothing to do with value or accountability, a lot more to do with payment, and everything to do with managed care. Value-based is really valueless. So if you take nothing away in the next 35 minutes, please take this away with you, that this value-based care and value-based payment has little to do with care, nothing to do with value or accountability, and a lot more to do with payment and everything to do with managed care. Because what happens is that we think of value-based care, and then our mind just starts to think, okay, well, it's got something to do with value and something to do with care, and that's where we go wrong. So all value-based payment does three things. They all insert a middleman. They all use performance measures to incentivize doctors, and they all set up spending targets, also known as benchmarks. Now let's go through this one by one. One, all value-based payment inserts a for-profit middleman into traditional Medicare. Now, remember that slide that I showed you about fee-for-service? There was no middleman there, but now there is a middleman that manages the risk of taking care of a patient on traditional Medicare. And the difference between this middleman and those in Medicare Advantage is that now, by becoming accountable, the doctors also share the financial risk of caring for the senior. Increasing financial risk for the doctor means the doctor is now on the hook to produce savings. Now, we don't need to get into the weeds. However, these doctors are actually being reimbursed by Medicare still under fee-for-service, but they agree to take a lower percentage of that fee-for-service reimbursement. So they have to make up that loss through their shared savings. Now, traditionally, for a doctor to provide good care, they need autonomy, they need continuity of care, and they need trust. And this is not what value-based payment provides doctors or patients. In fact, they do the opposite. Number two, all value-based payment ties the doctor's financial incentives to performance measures such as quality, health outcomes, and cost. There's nothing wrong with quality, health outcomes, and cost. I'm all for it. But remember, how will you measure quality? Which health outcomes do you choose? What happens if a patient sees multiple doctors? Who gets to share the leftovers, the shared savings? Instead of autonomy, continuity of care, and trust, how well these doctors perform on these value metrics determines how much savings they share. So value-based payment undermines the relationship between the doctor and the patient, making the patient ask, whose best interest does this doctor have? Mine or the for-profit ACO? Three, all value-based payment sets up spending targets, also known as benchmarks, for every traditional Medicare beneficiary in their panel. So if doctors and middlemen come in under the target, they increase their savings, meaning their profits. But if they come in over the target, depending on the financial arrangement they have with Medicare, they might owe Medicare money. So let's just take an example. Medicare gives value-based company Good Profit $1,000 to take care of Mr. Jones each month. If the Good Profit doctor only spends $800 on Mr. Jones that month, good profit and the doctor save $200 and get to keep a certain percentage of the $200 as profit. But if the good profit doctor spends $1,200 on Mr. Jones that month, good profit and the doctor owe Medicare $200, and how much they owe depends on the financial arrangement with Medicare. Autonomy, continuity of care, and trust go out the window. Our competitive healthcare system is driving doctors to sign up with ACOs and then driving them out of the profession due to burnout and moral injury. The next time you try to find a PCP and you can't, value-based care might be one of the reasons. Now, we care about valueless care because financial incentives motivate doctors and middlemen to deny and skimp on care to maximize profit. Remember, they're going to try to do everything they can to come in under that spending target, that benchmark, right? So what are they going to do? They're going to seek healthy patients who cost little. So if Mr. Jones costs them $800 a month, what they're going to do is they're going to look for Mrs. Jones, who they know predictably only costs them $500 a month. And what they're going to do is they're going to avoid Mr. Smith, who they know predictably costs them $3,000 a month, right? And they're going to do something called upcoding, a trick perfected by Medicare Advantage that adds diagnoses to patients, right? To get more payments, meaning a higher benchmark for healthy patients, for that Mrs. Jones that only costs them $500 without spending a penny more on their care. The middleman might even avoid doctors who take care of sick or poor patients to maximize their profit. So Dr. Malinow, you take care of too many, Mrs. Smiths who cost $3,000 every month. We're going to drop you from our plan. This drives physician burnout, physician shortage, that leads to a lack of primary care and actually ends up decreasing equity, not increasing equity. Now, here goes the 1-minute elevator speech on valueless care. Number one, and most important, value-based payment has nothing to do with value. It inserts a for-profit middleman between Medicare and the beneficiaries on traditional Medicare. It shifts the financial risk from Medicare to doctors. It rewards doctors financially for meeting performance measures and for spending under their spending targets. It's managed care all over again. It incentivizes cheating, skimping on care, cherry-picking healthy patients, lemon-dropping sick ones, upcoding patient diagnoses without spending a penny more on their care, and greater inequity. So, how did we get here, flying with a valueless parachute? Well, the Affordable Care Act of 2010 created two pathways that permanently changed the way traditional Medicare would be reimbursed away from fee-for-service, that evil fee-for-service, towards value-based payment. Now, one pathway was through Section 3022, which established the Medicare Shared Savings Program, also known as MSSP, and the creation of groups of providers called accountable care organizations to be accountable, meaning to take on the financial risk for a group of beneficiaries on traditional Medicare. And ACOs manage the care of seniors on traditional Medicare and share the savings that they generate. Now, the question becomes, though, how to get these beneficiaries who rejected Medicare Advantage because they didn't want networks or prior authorizations to enroll into an ACO? Well, you don't. You entice their PCP to join an ACO. Beneficiaries are then aligned to their primary care doctors automatically without their knowledge or consent. And some of you might already be in one. And then the other pathway was through Section 1115A, which established the Innovation Center, or also known as CMMI, under the Centers for Medicare and Medicaid Services, for the purposes to test models to take financial risk, manage the care of seniors on traditional Medicare, and share their savings. And how do you enroll beneficiaries? You guessed it, they are enrolled through their PCPs without their knowledge or consent. Now, don't worry if you're confused. I imagine everyone has seen The Godfather here, right? And if you haven't, please rent it tonight and watch it, because all of this will become much, much clearer if you do. Now, remember Vito Corleone, The Godfather? He is value-based payment, the big overarching concept. It's the new alternative payment that replaces fee-for-service. And value-based care is the way to deliver care using value-based payment. Michael is the Medicare Shared Savings Program, also known as MSSP, and Fredo, the incompetent son, is ACO REACH, a tiny family spinoff, one of the value-based care models that we are going to be looking at in a bit. Now, to think of this diagrammatically, we have value-based payment as the umbrella or the godfather, which spawned the Medicare Shared Savings Program and the Innovation Center under CMS. To operationalize this value-based payment in traditional Medicare, meaning to move from fee-for-service to value-based payment, you need to have doctors in some kind of an arrangement to pay, and the arrangements became value-based care, using accountable care organizations to pay for value instead of for volume. Now, what they didn't realize was just how much more cheating would ensue from value over volume, or maybe they did. We will briefly look at one such ACO called the Vermont All-Payer ACO, and then we will also very briefly look at an ACO called ACO REACH from the Innovation Center. Now, the Vermont All-Payer ACO is an example of a very big ACO. In fact, in 2017, the entire state of Vermont signed an agreement with CMS to accept full accountability, remember, full financial risk, for the total cost of care for all people living in Vermont, including all payers, so not just Medicare. And to do this, Vermont established One Care ACO, a for-profit ACO that was put in control of all of Vermont's healthcare system. What could possibly go wrong? After 7 years of operation, its operating costs were almost $100 million, and that was in addition to the already existing administrative costs of Medicare and the Medicaid, MCOs, and CHIP, and the commercial insurers. And to pay for their overhead and profits, the ACO levied dues on rural hospitals, not urban hospitals, rural hospitals, and primary care practices. And what they also did is they reduced the reimbursement for primary care, mental health services, and home health agencies with promises to earn the difference back at the end of the year if performance goals were met. Now, this drove many doctors out of the state of Vermont. And One Care, at the end of their 6 years, failed to reduce costs, slow the rate of growth, or improve quality compared to those individuals who were not in ACOs in Vermont. And nevertheless, CMS re-upped their contract and they signed on for another year of this. In 2022, there were 482 Medicare Shared Savings ACOs that covered 10 million beneficiaries who signed up for traditional Medicare but found themselves in an ACO without their knowledge or consent. And in that 1 year, ACOs saved Medicare $1.8 billion, but the ACOs made $2.5 billion for themselves. And this is a list of the top 10 performing ACOs in 2020, and you can see that they're all LLCs, another name for a corporation, and the amount of money in millions they made for themselves in just 1 year on the right-hand column. And I'd like to highlight just one profitable ACO called Stewart National Care Network, the nation's largest physician-led private for-profit healthcare network and ACO in the US. It's worth noting that in 2022, Stewart Healthcare System agreed to pay $4.7 million to settle a case alleging kickback payments. So it's a whistleblower case alleging kickback statements for patient referrals to its ACOs. But this, of course, was peanuts because right after the lawsuit, they were acquired by CareMax, a publicly traded company, for $135 million. So let's switch now to the Center for Medicare and Medicaid Innovation, or the Innovation Center. ACO REACH is a typical value-based care model from the Innovation Center. ACO REACH started as direct contracting entities under the Trump administration, and it was green-lighted by the Biden administration as ACO, which stands for Accountable Care Organizations, REACH, Reaching Equity, Access, and Community Health. And just like every other value-less payment model, inserts a for-profit middleman called an ACO REACH in this case that agrees to take accountability that is to share the risk to manage care for seniors on traditional Medicare. Now, who or what are these ACO REACH middlemen? Well, virtually any type of company can apply to be an ACO REACH, including commercial insurers that include Medicare Advantage plans, private equity firms, venture capital investors. All of these applicants are approved by CMS without any input from Congress. And if you'd like to look at the list of these middlemen, you can go to that link. Now, over 2 million seniors and people with disabilities on traditional Medicare have been forced into an ACO REACH without their knowledge or consent through their primary care doctor who has joined an ACO REACH, just like the seniors whose doctors joined an MSSP ACO. And if the senior wants to opt out, well, they have to find another primary care doctor, and we know how easy that is. Now, after being in operation for 10 years, the Congressional Budget Office finally published a report in September on the activities of the Innovation Center, because remember, they were created under the Affordable Care Act in 2010, and they found that their models increased direct spending by $5.4 billion. And not only did the center increase spending in the first 10 years of operation, it will continue to do so into its second decade. Now, all value-based ACOs threaten senior choice, senior medical care, and even the Medicare Trust Fund. How? Well, traditional Medicare beneficiaries are forced without their knowledge or consent into one of these ACOs. Doctors have financial incentives to skimp on care, to increase profit by cherry-picking healthy patients and lemon-dropping sick ones. And while traditional Medicare spends 98 cents of every dollar on healthcare, spending only 2 cents of every dollar on overhead, ACO REACH, for example, can spend as little as 60 cents of every healthcare dollar on care, keeping up to 40 cents of every healthcare dollar for profit and overhead. And while it's probably unlikely that they're going to be keeping this much money, for sure, 75% for care and 25% for profit and overhead will probably be likely. Nevertheless, according to CMS, all traditional Medicare fee-for-service beneficiaries will be in a care relationship with accountability for quality and total cost of care by 2030. And what they mean by a care relationship is value-based share risk payment with a profit-seeking middleman. This means that all Medicare, Advantage, and traditional is threatened by privatization. Now, it has taken us 20 years to go from most Medicare beneficiaries choosing traditional Medicare, right in the blue, to today, where half of Medicare beneficiaries choose Medicare Advantage. But CMS has already chosen either ACO REACH or another type of ACO for about 4% of beneficiaries on traditional Medicare, the Medicare Shared Savings Program for about 18% of their beneficiaries, and by 2030, will have chosen some kind of organization accountable to manage the care of all seniors. So we have seen what 58 years of accommodation have brought us. No more accommodation. It's time we fight the profiteers. And we have, as a result of the tremendous organizing, including from many people in Kentucky and in Pennsylvania and all the other states represented here, 300 organizations across the country have signed letters or passed resolutions against ACO REACH. And in California, 24 California County Democratic County Central Committees and 5 California Central Labor Councils passed resolutions against ACO REACH. And here in Kentucky, you can see the full list of the organizations that have signed letters opposing ACO REACH. And on September 7th, the whole California State Assembly passed Assembly Joint Resolution 4, also known as AJR 4, introduced by Assemblywoman Pilar Schiavo, making California the first state in the country to go on record opposing ACO REACH in the corporate profiteering in Medicare. It was really an incredible achievement that we were able, through grassroots organizing to get the entire state of California to go on record opposing ACO REACH and profiteering in Medicare and corporate profiteering in Medicare. That's what the resolution says. Now, we have been very fortunate that Assemblywoman Chavo, who not only introduced but also championed AJR4, also known as Assembly Joint Resolution 4, it's a mouthful, has written and sent a dear colleague letter to the entire California congressional delegation, asking them to support AJR4. And alongside other organizations and central labor councils, what we're planning on doing is to visit or plan to visit every member of the California congressional delegation. And to do this, we have already trained over 30 activists on value-based payment who will go out and educate their member of Congress about valueless care and the threat that this poses to Medicare. We're asking them to sign a pledge that will protect seniors, especially important to protect constituents who vote during an election year, to support Assembly Joint Resolution 4, and urge President Biden and Secretary Becerra to end all valueless payment in traditional Medicare, including ACO REACH. So this pledge not only talks about ACO REACH, but also talks about, you know, the godfather, the whole overarching concept of value-based care and value-based payment. Now, we have created a Google folder with a packet that will make congressional visits very easy. And any of you who are interested, please email Kay, and then I will give you access to this Google file. We've targeted 3 districts to start with, and we're already creating teams, district captains, and so forth. And we're going to take these lessons learned once we do these 3 pilot districts, and then hope to visit every U.S. congressperson in California, or at least the Democrats, and then maybe even hope to target members of the Congressional Progressive Caucus and start training their constituents to get the CPC members to sign a pledge supporting AJR4. And then to pledge to urge President Biden and Secretary Becerra to end all value-based payment, including ACO REACH. So this is how we're operationalizing our movement to end privatization of Medicare. And this is some of the stuff that you can find in the Google Drive. It has the Dear Colleague letter, has a handout called Why Seniors Oppose Value-Based Care. It has a letter that you can give to your member of Congress, the pledge of support, and then a glossary of terms. These are some resources on value-based payment. I know that Kay has already sent you some. Here are some more, some of these written by Kay. And I'll be very, very happy to answer all of your questions.
Okay. Wow. Thank you, Dr. Anna Malinow, for that amazing presentation. And you're getting muted applause, I see, as the people
Thank you.
are clapping through their muted Zoom calls. Well, people didn't put questions in, but I have found 2 people here have questions, and we will open this up for others who would like to have questions. Perhaps you could raise your hand or put something in the chat. And the first question was from Dr. Mike Flynn.
Doc, can you hear me all out there? Dr. Malinow,
Yes, I can hear you. Yes, thank you
very much. That was an excellent presentation. And I've got to tell you, that was an eye-opener. I'd like to sort of ask you a question and maybe another one after you've answered the first one. But from what you've said, the value-based care, the ACOs, the ACO REACH, Medicare Advantage, these were all initiated by CMS. This? I didn't realize that. I just want to make sure I clearly understand that from your wonderful presentation. This sounds like a self-inflicted wound to me.
Yes, one clarification there, that CMS did not create Medicare Advantage technically. Medicare Advantage was the old Part C, and as we know, Part C was, I believe, created by President Clinton, and then Medicare Advantage became Medicare Advantage under President Bush in the 2003 law that was called the Medicare Modernization Act of 2003, I believe. And, 2003. So I wouldn't put Medicare Advantage as part of CMS, although CMS does oversee Medicare Advantage. Now, when you say value-based care, ACOs, and REACH, yes, they are under the purview of CMS, and CMS does run those. Yes. Now, ACOs are mostly under Medicare, but there are some ACOs that also function for commercial plans as well, and those I don't believe that those are under the purview of CMS. But the vast majority, almost 500 ACOs, are under the purview of CMS because that's how many ACOs there are under Medicare.
Yeah, again, the point is all of these middlemen didn't get in on their own. They were invited in by CMS. And now, so let me ask you the second question. You know, we're all here for the purpose of trying to establish a system that provides essentially Medicare for all, not just old people like me and Gene Shively and Garrett and some of the other people on the program. So what I'm thinking, I'm listening to this thinking, what a nightmare of middlemen can we expect if we manage to get a system of Medicare for all in this country. We've created this nightmare of middlemen upcoding and sucking profit out of the system and basically depleting the Medicare fund. Do you have some thoughts about that? How that would work in a system that would provide essentially the same government-run health insurance for everybody else aside from geezers like us?
You know, that's a really, really, really good question. And that's what worries me about us talking about getting rid of Medicare Advantage, right? Because then we still have all the profiteers that are left in traditional Medicare. So single payer, as we know, is defined as public financing, but private delivery. So that's single payer. And under a single payer system, under a Medicare for all, we would not have Medicare Advantage because we would be getting rid of all the private health insurance companies. But we would still have all these middlemen that would be left over from traditional Medicare. Now, HR 3421, that's the Jayapal bill, I think there are some really great things about it, and then there's some deficiencies, and Kay can speak to the deficiencies much more eloquently than I. But one of the things that it does do is it gets rid of all value-based payment schemes in Medicare, which I think would be good. But unfortunately, it still leaves the for-profit hospitals and the for-profit facilities and the for-profit dialysis units in place. And that would be basically siphoning our public money into these private players. Yes.
Well, listen, thank you again for that excellent presentation. I'm going to have to go drink some Irish whiskey after this. So thank you. Appreciate it.
Okay. Thank you, Mike. I saw that Dr. Eugene Shively had a question. I don't see where he is. Oh, wait, he's on mute.
He's muted.
You're muted, Gene.
Thank you very much, Hannah. This was a great talk. I don't understand the motivation of CMS. Why would they continue a system that is losing money? What's their motivation for that?
You know, I cannot get into the head of CMS. I think that I would go crazy if I did. To me, it makes no sense whatsoever why they take these ACOs that they know are basically ripping them off and still giving them money. It makes no sense whatsoever. But I believe what it is that they have an ideology, which is, fee for service is the reason why we have our healthcare system is the way that it is. And what we need to do is to get rid of fee for service and replace it with value-based payment. And that's what the Affordable Care Act gave them the mandate to do. That basically says it. If you look at the Affordable Care Act, and if you look under the section 32, I forget now which that section that I mentioned, and you read it word for word, that's really what it says. We're going to be replacing fee for service and replacing it with value-based payment, which is the value-based care models. And why the motivation behind CMS? Well, I think the one way, the nicer way of looking at it, the more generous way, is that they really believe this, that they believe in this ideology. I think another way of looking at it, which is not quite so generous, is that they come from industry, and there's a revolving door at CMS, which we can point to, and it's a revolving door that they know what they're doing while they're in government is that they're going to be increasing the profits of their buddies in industry, because that's where they're headed after they finish their term at CMS. So that would be my explanation for the motivation.
One other question is, has anybody done a study on comparing Advantage plans and value-based care with traditional Medicare? It seems like it would be easy to do that. You could study the morbidity and mortality of the two systems. People who do these type of population studies with fancy statistics should be able to come up with some answer in 5 years.
Right. So yes, these studies have been done. One of the things that these alternative payment models have to do after a certain number of years is they need to have studies, evaluation studies done, and their evaluation studies are for costs. The amount of money that they're saving is minimal, like $1.8 billion sounds like an awful lot, but the entire Medicare budget, I told you, was $1,000 billion, right? So it's a drop in the bucket. As far as outcomes, their outcomes are mixed. Some are good, some are not. I think what's really remarkable is if you look at the evaluation of this Vermont ACO, this all-payer ACO, it's just, I mean, the way that CMS is spinning it is that they did save money, but then when they compared it to, so this Vermont ACO only covers 40% of Vermonters, which sets up a natural experiment so that you can compare costs and healthcare outcomes between those who are in the ACO and those who are not. And even though they're saying that these ACOs save money, when you look at individuals who were not in the ACO, their the costs for traditional Medicare were even lower, much lower than those that remained in ACOs, and their health outcomes were better as well. So it's just remarkable what they get away with. It's just shocking and stunning. Yeah. Those studies are out there.
It's very interesting to me that how I don't want to use the word ignorant, how uninformed a lot of physicians are about these systems. For example, I had a conversation with a very, very bright guy just a couple of days ago. He was a retired chairman of a very powerful department of surgery, and he did not have any idea about Advantage Medicare. So we got a problem with physicians understanding these problems.
Mhm.
Agree.
Okay, I see that Charlie Casper has a question.
Yes, doctor, thank you for a wonderful presentation. My question is, I am a member of an ACO, not by my choice. It's a Baptist health system. And if I go to my primary care doctor and I need to see a specialist, I can see that specialist on my own. Is that correct? That I already have a relationship with. So let's say I need to go to a cardiologist, for instance, and I have a cardiologist, but that has nothing to do with my primary care doctor. So she continues to treat me for the savings that she hopes by my health being good. So the same token, I go to a dermatologist who I have a relationship with, and I can go to him or her directly. Now, is that one way of trying to get around how the primary care doctor controls what she does in way of treating you?
Well, it depends. It depends. If you are in traditional Medicare without an ACO, then yes, you have the right to go to any doctor, any specialist, any hospital that accepts Medicare. Under ACOs, however, that might not be the case. And when you want to go to see your cardiologist, what will happen is that it behooves your PCP to try to control that, to maybe say, okay, well, maybe I can do that stress test, or maybe I will send you to a cardiologist that is within our network, because that's going to save us money. If you go outside of that network, Medicare is going to reimburse that cardiologist, and then that payment is going to be taken out of that benchmark that your ACO got for your care.
Okay.
And so you're not getting around it. It depends on the ACO, and some ACOs are really putting the brakes on the number of visits that you have with specialists, the specialists that you see, the hospitals that you go to, and so forth.
They can control that.
Yes.
Oh my. Okay.
You should ask. You should ask your PCP.
Okay. Well, thank you.
Okay, I see that Dr. Scott Tyson has a question, and that's followed by Harriet Seiler.
Hi, everybody. Anna, that was a good presentation. It was depressing as shit, but it was a good presentation. As you know, and Ed's on too, and Ed and I have been working on this for a long time, and I know you have, and I know Kay has. Anna, obviously this talk carved out Medicare, but I mean, Ed and I worked on a conference. Ed, it's got to be 30 plus years ago, where Dennis Kucinich came in from Ohio, and as you know, we've been working on this. I haven't, but since 1906, and it just seems to be getting worse and worse and worse by the minute. Anna, how do you keep your spirits up when it just seems like every single system that is run even remotely positively is appropriated by the for-profit network and the medical industrial complex, to the point where we're arguing about the same things that we argued about. I mean, for us, 30 years ago, but for other people, 120 years ago, to the point where, it now we're fighting Medicare Advantage. Before we were fighting HMOs. Before that, we were fighting the American Medical Association, and it goes back and back and back. And I think, Ed, not to rain on your parade, but I think the reason I pulled out of the other groups, and I still educate constantly, is because I literally feel like I've been banging my head against the wall for 30 years. So sorry for the depressing commentary, but do you have any comment, Anna, on how you, other than drugs and alcohol, do you have anything that you've found that will help you cope with this situation. I apologize, everybody.
No, Scott, you bring up a really good point, and I think a lot of us feel that at one point or another, for sure, for sure. Have I found, the magic bullet to keep me going? I don't know what it is. I think that I don't know. Maybe others have. I mean, I agree. I think that it is getting worse by the minute. It's not getting better. Some people would say, well, it's our capitalist system that, I mean, this is sort of the inevitable outcome of trying to privatize everything,
Right.
including our health, our debt, our water, everything. But the thing is that
You have to keep going on. I
I
think
do.
if you give up, you
I don't
just
know.
give up.
I don't know why. I just think that my father used to say about getting old. He hated getting old, but he always used to tell me the alternative is so much worse.
Right.
Well, I kind of feel that way about.
I hear you, and I don't
healthcare
mean to rain on anybody's parade, Anna. I've stopped looking at the news because I get so depressed that I just, I don't watch the debates because everybody is trying to out Trump, and it's like, you got to be. I won't use the F word, but you got to be kidding. So, thank you for doing it. I appreciate all your efforts, and I applaud everybody at this group.
Thank you, Scott. Thank you.
The next question is from Harriet Seiler. You're on mute, Harriet.
Thank you, Anna. That really was wonderful. I didn't understand a good third of it, I'm sure. But it was interesting when Mike Flynn asked his question, because I had written up in the margin role of private investor. And that's because I'm loving that new word plunderer, the plunderers, that is it Gretchen Morgenstern, I think, wrote the book called These Are the Plunderers. But I'm always tweeting and saying something about the fact that CMMI, that agency that that's an offshoot of CMS, in my opinion, is inviting the private investors in. Well, I thought they were inviting them into the local clinics and setting up, like here in Louisville, we've got Oak Street and we've got Centerwell. And I thought it just shouldn't be the role of our government agency to be inviting in these private investors. Well, even I had no idea when I saw that list that you put up recently, right near the end, that list of ACOs that are all LLCs. I mean, one of them, of course, is our Baptist East one. I belong to the same one that Charlie Casper belongs to, with our Baptist East Doctors and Hospital. And we were all shocked when we got the notice that they were an ACO. All right, now where am I going with this? Okay, my own primary care doctor said the savings are pennies. They're not at all significant. And if they did make any extra money, it should go to staff in their offices, not to the physicians. I thought that was interesting. Now, the other thing is, and I don't know if there's a question there, I just want you to, I guess, comment on that invitation to investors. But I do want to also say that I'm originally Canadian and my family's all up there. And I know how the Canadians, run their Medicare. At least I think I do. But does anybody know? Well, I know in Ontario, Kay just sent me a message saying that under Ford in Ontario, that the thin edge of the wedge is getting in. He's talking about allowing for private clinics. And I know that they do kind of set up teamwork where they're encouraging teamwork and that sort of thing. And I'm sure they talk about cutting costs. But anyway, so first question is just a comment on CMMI. Actually inviting investors in to profit off our healthcare. And then the other is, do you know what the latest might be going on in Canada in order to kind of curb an influx of ACOs?
So I agree with you. Thank you so much for that question, Harriet, because CMMI actually is inviting private investors, and it came out of the mouth of Liz Fowler, who is the director of the CMMI, when she was being when she gave a talk to the CalPERS, which is the California now I'm going to forget exactly what that acronym stands for, but it's the retiree arm of the public employees in California. And she gave a talk to their board where she was asked specifically about private equity. And she says that she verbatim said, well, not all private equity is bad. It depends on what they what they want to do, and I think that just says it all. That Liz Fowler, who is running the CMMI, is perfectly fine having private equity take our public money. So yeah, I think they definitely are inviting private investors in. I think that they have no qualm whatsoever with that. Regarding the savings that you were talking about, that your physician was talking about, I agree. I probably think that the savings are pennies, and any savings that they get, they probably do want to increase their staff, because the physicians themselves are so overworked and burnt out that if they get any money at all, they want to give it to hiring more staff. But remember what I said is that under the ACOs, they still get paid through fee for service, but they are agreeing to a lower reimbursement from Medicare. So they have to make up the savings at the end. Otherwise, they're just never going to be made whole, and they're going to be running a business at a loss. Yes, and in Canada, there is a huge fight to start privatization. In fact, I recently published a letter to a journal called Longwoods in Canada that was a response to their editor writing about how Canada should look to the United States for how to privatize their healthcare system using things like value-based payment and ACOs and Medicare share savings and so forth. And it's frightening. It's frightening. See, what's happening here in the United States is that eventually these corporations, these capitalists, are going to run out of money, right? They've already run out of money from the employer side. So now they're shifting, like Humana, for example, is no longer they're no longer selling employer-sponsored health insurance. And they're just all focused on Medicare Advantage, because they know that that's where the money is. Eventually, that money will run out as well. And so what do? They're just going to look internationally to the public programs there.
Thank you very much. Thank you.
Let me just make a comment about Canada. I just recently got back from a cruise where we left from Quebec City, went up St. Lawrence River and around the Prince Edward Island and Nova Scotia. And I was asking a lot of people about the health care, and I was told that the ER visits now are a long wait, many hours. And also told that physicians cannot set up private practices, but nurse practitioners can. And a lot of nurse practitioners have now set up private practices where they're seeing patients outside the Canadian traditional system.
Yeah, I don't know anything about that, but I do know that there are physicians in Canada that have private practice. So I'm not okay. I'm I'm not enough of a Canadian expert to tell you that.
Well, you know, we have a nice wait in US hospitals.
I was just
Well,
going to say that too.
I don't think Canada's is an issue.
Okay, I'd like to, I want to thank Steve Katz for giving us the link to everything anyone has mentioned. He is amazing. And he has pulled out the links to the Liz Fowler's CalPERS statement and to many other things. So check and save your chat if you want to have access to Steve's notes. And I now see 3 questions. So let's take them. I think Sandra Klassen, and then Claire Cohen, and then Scott Tyson.
Hi, everybody. Can you hear me all right?
Yes.
Oh, good. I just got an email from a friend of mine today, or a text that is very concerning. It's brand new. She's a retired federal employee, full career in the civil service. I've of course told her a lot about what our groups are working on. So she wrote me today that the federal employees health benefit plan is now, for the very first time, she just got her brochure offering a Medicare Advantage version. She said, I really don't know what this means for the future of the federal program. I have no interest in changing to the Part C version because of my general aversion to Part C. I don't know if any other federal plans, there are hundreds, will be making similar offerings. But I think it's significant because there are millions of employees, retirees, and former spouses covered by health insurance plans in the program. Seems that the administration is determined to push Part C. Were any of you, Anna, or anybody aware that they've now, for the very first time, inserted Medicare Advantage? This is like the first time, and she's been retired a long time. So I've given her all the red flags to look for. This seems astonishing to me, with the evidence coming out about Medicare Advantage fraud, et cetera, that they have now gotten into the federal employees, millions of people, as an option. And I asked her to do an analysis, and quickly, I mean, this is all recent today. And she said, of course, what they're doing is offering the dental and the vision and some of these things. She sees it very clearly as the Trojan horse in the door. Anybody know about this?
I do, Sandra. I have been in communication with someone in Washington who is a retired federal employee, and he is saying the exact same thing. But I think that it's even more insidious than that. So the way that it was offered to him is he has to pay for a Medicare Part D plan, which is somewhat not very expensive, but it costs some money. And what he was sent was the opportunity to sign up for Medicare Part D that was free. And as a matter of fact, that he would be automatically enrolled into that free Part D unless he opted out.
Oh.
And because he's smart and he knows that there's no such thing as a free lunch, he investigated this, and it turns out that if you don't opt out, then you're automatically going to be signed up for this Part D, which will kick you out of your federal employees health benefit plan, will just give you a Part D, which will then mean that you have to sign up for Medicare Advantage.
Oh my God.
It is so awful. It is so awful that I think somebody really needs to just start, sending alarms and ringing bells about this, because I think what they're doing is very insidious. And a lot of people are saying, oh, wow, free. Okay, why not? And then they're really going to find themselves in trouble.
She also, now that I'm looking at some other texts from her following that, when I asked her to do her best analysis, because I didn't have time to this afternoon, she also said they offered to their Part C would pay the Part B premiums.
Right.
Which also is very enticing to some people.
Absolutely. Mm-hmm.
Dr. Claire Cohen has a question.
It was more some comments to things people had said. One, what Harriet raised about, well, Canada, but I wanted to just expand that to say it's not just Canada. The British system is well on its way to being dismantled.
Right.
And I have a friend who lives in Finland, and they're working on. So I think this is going on all around the world. Is these capitalists, they're being very aggressive in trying to dismantle single payer national health programs. And unfortunately, and people are saying, why is this happening? It's because all of these politicians all around the world are paid off. There's some famous quotes, and I don't remember them, so I'm not going to say them. But the essence of their quotes is correct. So when you look at these super rich people, billionaires, there's some studies that have been looked at this. What do they spend their money on? Corrupting governments. Okay, so that's the big problem we have, that we have these 1 or 2% of the people in the world who just, you can only sleep in so many beds, you can only cook on so many stoves, you can only eat out of so many plates, but you can certainly use all that money. And it's not just in healthcare, to corrupt governments, and from healthcare to cops. I don't know if any of you have been following the climate thing. It's to all kinds of things. It's just, and that's where we tie in with other efforts. And that leads to what I was going to raise when Scott was saying, what do we do? Scott, I don't have all the answers, but one of the things I know, we have to connect with other activists in other struggles to help them understand, because I still see, I go to these Black activist things, Black revolution, and everybody's talking about this or that, but their understanding of what's going on in healthcare is so poor and so oversimplified. So everybody's going Medicare for all, but they have no idea what's really going on. So I think, I don't know whether one of the things is getting together with activists and some, and this would have to do with the privatization thing, I don't know what we're calling a conference, I don't know, getting together with some of these activists and some of the housing, healthcare, some of the people fighting debt, some of the people fight, not just medical debt, but I mean, and just having a powwow, making sure we all understand what's really going on. That's one of the things, because I think it would definitely help if more people understood how things are we're just being sold down the river, and things are being, as you said, Anna, it's insidious, how insidious this privatization stuff is. And then we talked about maybe strategize something, because I think that a lot of people just don't get it. They think all we have to do is have Medicare for all and we'll be okay. I hear that all the time when I go to conferences, and I say, how come there's nobody talking about healthcare? Oh, well, we all want Medicare for all, but it's as if that's the simple thing. But I think we need to really do our best to do more education, is what I'm saying, because the only way we're going to get anything to happen, to get the movement, is if more people get a clear picture. That's why I was asking, was this recorded? Because sometimes we forget to record things. I was making sure we were, because we need to be able to show this as much as we can and talk to people as much as we can, other activists, and a few of the people. I think there's 12 Congress people that haven't been bought off, from what I've read. Maybe those 12 to help educate them. And I'll just leave it there.
Okay, is there anyone who has not yet asked a question who wanted to get into this discussion? Lynn?
I'm trying to put a link on the chat and I can't figure out how to do it. Are you hearing me?
Yes.
Yes, we hear you.
How do I put a link on the chat for everybody to,
You
Just-
have chat open.
yes,
At the bottom, you should be able to type into the message at the bottom. Click in there.
There's a space right
Okay.
under where in blue it says meeting group chat. If you click in there,
right,
There it
okay.
is.
We got it.
Now wait,
We
I
see
want,
it. We
I
see
want
it.
to add one more thing.
from the Tucson Sentinel.
Anyway, look at that Tucson Sentinel link if you haven't seen it already. They're inviting citizens to become fraud detectives.
Yeah, I saw that, Lynn. I honestly think that it's a sad statement on our country where we have to ask seniors to figure out how they're being defrauded by their government in Medicare.
Yeah, that was my reaction.
Oh, sorry. I thought you were
No,
telling.
I
Go
mean,
ahead.
exactly why I would like everybody who hasn't seen it to read it, because it's ridiculous.
I see. Yeah.
Very nice of them.
Okay. Anyone else who hasn't asked? If not, I still see Sandra and Scott have their hands. You have another question?
I would just like to ask to thank Anna. This is Garrett. I don't know where I am now. Oh, there I am. Anna, that's great. And thank you for your strength and courage to go through this and help us all try to learn it. Thank you.
Oh, thank you, Garrett. It takes a village.
Maybe a big city.
Or the country, or the whole country.
Or the whole country, a few million, but we've got millions on our side. I just saw the figure yesterday that we have 100 million who have medical debt. So a third of the country is in debt, even though we have supposedly moving towards healthcare for all. So Sandra and Scott, did you have a final question?
I just, if you wouldn't mind, I just wanted to
No.
say I just wanted to say one thing to Dr. Shively. Ann and I both worked in Pittsburgh, and Dr. Shively, during the summer, Children's Hospital had a wait of 9 hours, and the psychiatric facility here has a wait of 2 to 3 days in the emergency room. So we have a nightmare system too, and so again, I applaud everybody for the efforts that they've put in. I didn't mean to rain on everybody's parade. That was not my intent. I think that what I hope that we do is, as Claire said, continue to work on the intersectionality of all of these issues together, so that it's not my problem versus your problem and your problem and your problem, but our problem, so that we can address these as a single problem that can be addressed with an umbrella of compassion, caring, and effort. So thank you all.
Okay, thank you. And if I see no further hands, and so I'll give Anne an opportunity. Did you want to have any closing remarks?
I guess I just want to tell everybody a little bit about the organization that has sort of catapulted me to do this. Obviously, National Single Payer, which is an organization that many of you know about, many of you belong to it, and we are an organization that fights locally for national single payer. We believe that healthcare is a human right, that it should be free of corporate profit, and that it can only happen through national legislation. The other organization that I'm involved in, much smaller, it's the Movement to End Privatization of Medicare, and it's mostly California based. And this is we are an organization of organizations. And we have worked with, particularly with CARA, which is the California Alliance for Retired Americans. I know that the Kentucky Alliance for Retired Americans did sign the letter against ACO REACH, and CARA has been very instrumental in organizing the state, and we've been very happy and very fortunate to work along with them. And our mission right now is to get our California congressional delegation to exert pressure on President Biden. I mean, I honestly don't know what it's going to take. Probably nothing, but at least what we're doing is we're educating. And I think the reason that we need to educate people about the privatization, particularly of traditional Medicare, is because when we are talking about Medicare for all, if we don't talk about the privatization of Medicare, there won't be any Medicare for all left to fight for. And I think that, I forget exactly who it was, maybe it was Dr. Shively, who mentioned that we really, we can't say, you know, privatize Medicare for all. But beyond that, I think that it is the way that we build a movement, of individuals that believe that healthcare is a human right and that it should be free from corporate profit. So we're sort of working at the edges, but our ultimate goal really is to have a non-corporate, profit-driven healthcare system for everyone. Yeah.
Amen. Thank you, Anna, and thank you to all of the people who participated in this session. I will hope that the recording will work out for us. And you can email me at nursenpo@aol.com if you'd like to get a copy of it. And I did save the chat, so if anybody wasn't able to do that, I could send you that as well if I get an email. So thanks everyone for your participation, and I'm going to stop.